So the first thing to know in abdominal anatomy, which is high yield, is what distinguishes between the upper and lower GI tracts. So that is the ligament of Treitz. And the retroperitoneal structures. So what structures are retroperitoneal? So there's an acronym for this, and it's SAD puckers, where S stands for suprarenal structures, which are your adrenal glands. A is the aorta / IVC. D is a duodenum, especially the second and third part of the duodenum. The pancreas is for P, ureters are U, C is for colon, especially the ascending and descending components of the colon. K is for kidney, E is for esophagus, and R is for rectum. So those are the SAD puckers, which are the retroperitoneal structures. Your intraperitoneal structures are the stomach, spleen, liver, first and fourth segments of the duodenum, jejunum, ileum, transverse colon, and sigmoid colon. So these can be very high yield to remember, especially for the surgery shelf and rotation when determining which structures are where within the abdomen. Some more abdominal anatomy. So this is a high yield point, and this is the transition between the small intestine to the colon, and it's a very important distinction to know, or transition point to know, because there's a narrowing of the lumen at this location. So this is referring to the ileocecal valve, and again, there is a narrowing of the bowel lumen at the ileocecal valve. And then again, a very high yield point to know within the colon are the watershed areas. So this will often be tested on the shelf exams and in the rotation itself. And the watershed exams are the watershed areas are the splenic flexure and the rectosigmoid. And these are really high yield to know because in cases of ischemia, these two watershed areas, the splenic flexure and the rectosigmoid, are at highest risk for bowel ischemia. So that would be any time, a patient would have hypotension, any shock like septic shock or hypovolemic shock, you can get essentially dead bowel or ischemic bowel at these watershed areas. All right, so moving on to just a quick picture of abdominal anatomy from the Blue Link website from the University of Michigan. So here you can see the duodenum, the first, second, third, and fourth part of the duodenum. So this is where the duodenum ends, and this is where the fourth part, or the jejunum, is. And then you can also see the ileocecal valve is within the duodenum. Next, moving on to some biliary pathology. So starting off with our first case, let's say we have a 40-year-old G4P4 woman that is presenting in clinic with recurrent right upper quadrant pain after eating spicy and fatty foods. The pain typically resolves spontaneously after about 2 hours, and her BMI is 30. She's currently afebrile, and then the vital signs and physical exam are generally unremarkable. What is the most likely diagnosis for this patient? So you should be thinking about biliary colic, which is also called symptomatic cholelithiasis. And treatment for biliary colic or symptomatic cholelithiasis. So treatment will be in elective, so not urgent or emergent cholecystectomy. And that's because, again, this patient is stable in the clinic and is having symptoms, which is essentially due to transient blockage. So if we have our liver and the gallbladder, and there you'll have your common hepatic duct and then your cystic duct, you're just getting transient blockage of the cystic duct as the stone passes through and the gallbladder is contracting. But the stone is ultimately able to pass through into the common bile duct. So some risk factors for gallstones include, I think there's some acronym that I don't actually really remember, but I think it's the 4 F's. But obesity, female sex, pregnancy, age greater than 40, and then some other separate risk factors for gallstones, although not always cholesterol gallstones, are malabsorption and TPN. Pathophys of biliary colic in particular is, like I mentioned, fatty food triggers CCK or cystokinin release, which leads to gallbladder contraction, because that's what CCK is supposed to do in the body, and you have a transiently obstructed cystic duct just because the gallstone is passing through the gallbladder. So we can imagine we have a bunch of gallstones in here. And what are the most common subtype of gallstones? The color of this pen kind of gives you a hint, but it's cholesterol is the most common type of gallstone. All right, very good. So let's say we have the same patient. Let's say she hasn't had her cholecystectomy yet, that is now presenting with a temperature of 104, tachycardia to 110, and abrupt arrest of inspiration with right upper quadrant palpation. You could say, gee, that's a very specific physical exam finding, and this patient also seems to be febrile, so they're not the most. So you can see they have some distress from their vitals. So your diagnosis will be then acute cholecystitis. So this is due to a kind of acute inflammation of the gallbladder. And treatment for acute cholecystitis. So this will involve IV antibiotics and then an urgent cholecystectomy rather than an elective cholecystectomy, because in this case, there is active blockage of the cystic duct by a gallstone. So remember that physical exam finding I alluded to, the abrupt arrest of inspiration with right upper quadrant palpation. So that should make you concerned for acute cholecystitis because there's a name for this sign, and that's Murphy's sign. And then some ultrasound findings of gallstones. So again, right upper quadrant ultrasound will be your preferred mechanism of imaging for almost any gallbladder pathology, but especially for acute cholecystitis. And with the right upper quadrant ultrasound, you can see gallstones, gallbladder wall thickening, pericholecystic fluid, which just is fluid around the gallbladder or kind of edema. And then you can see a sonographic Murphy sign. All right, next we have a 75-year-old critically ill patient. Vital signs are significant for fever with temperature to 102 degrees Fahrenheit, heart rate with tachycardia to 110, respiratory rate of 28, soft blood pressure 85/60. You get a right upper quadrant ultrasound, which demonstrates air within the gallbladder wall. What is the likely diagnosis? So the air in the gallbladder wall really gives this one away, and this should concern you for an emphysematous cholecystitis, which is when there's air within the gallbladder wall. Some risk factors for emphysematous cholecystitis are immunocompromised patients, especially diabetic patients in the question stem, and this is formed due to gas-forming bacteria, especially the Clostridium genus. Treatment of emphysematous cholecystitis, again, you should be thinking about broad spectrum antibiotics and then emergent cholecystectomy because this is a life-threatening condition. And then obviously stabilizing the patient if they're critically ill. Now let's say we have another 75-year-old critically ill patient with right upper quadrant pain on palpation, and vitals for this patient are fever to 102 degrees Fahrenheit, tachycardia with heart rate of 110, respiratory rate is 28, blood pressure is soft again at 85/60, and this time the ultrasound shows no evidence of any stones. So what is your likely diagnosis for this patient? So here you should be thinking about an acalculous cholecystitis, which is often seen in your severely ill patients. So patients in the ICU, patients with sepsis, organ failure, or severe burns. Treatment for acalculous cholecystitis. So treatment often involves, again, broad spectrum IV antibiotics, especially with anaerobe coverage. And also, you can consider cholecystectomy, but a lot of times these patients are very sick and not great surgical candidates. So you can think about PCT or percutaneous cholecystostomy, which is just a percutaneous drain of the fluid within the gallbladder. Next, let's say we have a 35-year-old gentleman, so you want to be thinking of the patient demographic, presenting with scleral icterus and a fever with temperature to 100.5, and then your physical exam demonstrates tenderness to palpation of the right upper quadrant. So they only gave you 3 exam findings, but these are very specific 3 exam findings. They're very carefully curated. Diagnosis for this patient is acute cholangitis, and treatment of acute cholangitis typically involves IV antibiotics and ERCP. This can be followed by a basic gallbladder removal cholecystectomy if cholelithiasis is present. Now, what were the specific 3 findings that were in the question stem? So you saw scleral icterus or jaundice, fever, and then tenderness to palpation of the right upper quadrant. So this just happened to be Charcot's triad, which is jaundice, fever, and right upper quadrant pain. So this is what you'll see most commonly in the question stem. And sometimes the examiners will like to go after Raynaud's pentad, which adds an additional 2 findings, which are hypotension and mental status changes. So the way I kind of remember this is I think of cholangitis as essentially an infection of the biliary tree. And when you have infection, especially the biliary tree, you can get first hyperbilirubinemia, which can cause jaundice. You'll get fever, and then you'll get right upper quadrant pain due to inflammation of the gallbladder and the biliary ducts. Now, in addition to that, you can see hypotension, which can be seen in severe infection, right? Just like with any severe infection, you can get hemodynamic instability and hypotension, and then mental status changes as well, which is something that can be seen in sepsis. So the Q-SOFA score is kind of an alternative to the SIRS criteria in assessing if a patient is septic. 2 of the criteria on the Q-SOFA score are actually hypotension and altered mental status changes. And the thing with Charcot's triad and Raynaud's pentad, they're not a sensitive marker, but they can be more specific for acute cholangitis. Now, let's say a patient has similar symptoms of kind of a jaundice picture and right upper quadrant pain, but they aren't having any fever. And then you might get some labs that show really elevated alk phos, really elevated T-bili, but not as high transaminases, although they still may be slightly elevated. So here you should be thinking about choledocholithiasis, which is when there's a gallstone obstructing the common bile duct. Again, if we draw that out, I know I'm not the best artist. In fact, I'm not an artist at all. But here we have our liver, and you have your right hepatic duct, your left hepatic duct, your common hepatic duct, your cystic duct. They meet up and form the common bile duct, and you'll have a gallstone maybe down here that's blocking the common bile duct. So cause your backup of bile into the kind of liver, which can cause elevated T-bili, and it'll cause some mild liver inflammation, but you'll also see significantly elevated alk phos, because alk phos is your measure of a cholestatic pattern of liver injury. Treatment for choledocholithiasis typically involves a ERCP, where you'll go in with a scope, and then you can make a little sphincterectomy and take out the gallstone and kind of sweep it out. Of biliary obstructive jaundice. So I'll let you kind of think of a couple on your own before I hand you out the laundry list of common causes that I have listed. Some common causes that I have listed are gallstones, biliary strictures, malignancy, especially cholangiocarcinoma, parasites, especially Ascaris lumbricoides, and biliary stents that become like occluded. Jaundice, as we know, is due to a buildup of typically conjugated or direct bilirubin in the liver and blood, because this is more water soluble, and you can also see dark urine in hyperbilirubinemia. On labs and imaging, again, we discussed this earlier, but you'll see elevated T-bili in obstructive jaundice, and then a significantly elevated alk phos greater than elevation of the transaminases, and that's consistent with a cholestatic pattern of liver injury. And then ultrasound, again, as I mentioned in bile duct pathology, right upper quadrant ultrasound will be your best friend for imaging of this area. Okay, so some subtypes of biliary tract disease. So our next case, let's say we have a patient with a history of recurrent cholelithiasis rather, and that's now presenting with abdominal pain, distension, and nausea and vomiting. and then your x-ray shows pneumobilia. What is the most likely diagnosis? And I'll give you a hint. The pneumobilia is kind of the exam finding that gives this question away. You should be thinking of a gallstone ileus, and that's typically due to a biliary enteric fistula, because you may be thinking, well, we have our gallbladder, we have our liver, and again, we'll make a little drawing. Be better at drawing this as we go along. And this empties into the duodenum. You may be thinking, how does a gallstone go from the gallbladder into the cystic duct, into the common bile duct, and then into the duodenum at this kind of at the sphincter of Oddi? So you may be thinking, well, that doesn't really make a lot of sense. So you're telling me that a gallbladder or a gallstone got all the way from the gallbladder through the ducts and into the duodenum and is now causing obstruction. But no, that's not what's happening. What's happening is in reality, the bowels and the gallbladder are next to each other within the abdomen. So you get a fistula formation where a big stone will go through into either the small bowel or the colon and typically obstruct at the ileocecal valve, which, as I mentioned, is the site of narrowing within the bowel. So treatment of gallstone ileus typically involves an enterolithotomy, which is essentially a fancy way of saying let's say the gallstone is here, you just go into the area typically open, and you just make an incision distal to the gallstone, and you remove the gallstone. So if the x-ray is unremarkable for pneumobilia, but you have a high suspicion, you can always get a CT. There's a reason that CT scans, that we call them the donut of truth, because they're often a good second option if you need additional imaging. And the pathophys of gallstone ileus, as I discussed. So you may see this phrase, so you don't want to be alarmed if you see it on exam, is a cholecyst enteric. So that just means gallbladder to enteric bowel fistula formation. And that is the tract through which our stone will get through from the gallbladder to the bowel. All right. Our next case. So this is a bit of a more difficult question. Some of you out there are probably you're saying, these are all so easy. I know everything about the gallbladder. Well, my friend threw this one in and I left it in because some of you need this question. So let's say a patient is presenting with right upper quadrant pain, fever, and jaundice. So again, this is commonly seen in a lot of right upper quadrant pathology or biliary pathology. Your abdominal CT shows a large stone in the cystic duct that is obstructing the common bile duct or compressing the common bile duct. What is the diagnosis? So in this case, you have your little picture, have your gallbladder, you have your hepatic duct, and then you have your cystic duct. So what is it called when a stone here is obstructing other ducts? So that's called Merizzi syndrome. And that's when you have external compression of either the common bile duct, which is a little more distal, or the common hepatic duct from external compression. And here you can kind of see a picture where you have a stone in the cystic duct that's now obstructing in the common hepatic duct or in the common bile duct. All right. Our next question, let's say we have a patient that has had a previous cholecystectomy. So you've taken out the gallbladder before, but now is coming back to you in clinic with return of their previous symptoms of right upper quadrant pain, especially after eating. Ultrasound and CT show no evidence of any biliary stones. So there's nothing really left behind. You did a nice job on your surgery because you did a nice job on your surgery shelf and you went on to become a great surgeon. Now this patient's symptoms are worse with opioids. What is your likely diagnosis for this patient? So you should be thinking about sphincter of Oddi dysfunction. And diagnosis, so there is a specific test that's often included on tests and especially MBME or shelf exams for sphincter of Oddi dysfunction, and that is manometry. And then treatment typically involves a sphincterotomy with ERCP. All right. We move on. Let's say we have a 31-year-old G2P2 woman presenting with a past medical history of hypothyroid that now has right upper quadrant discomfort and intractable itching or pruritus. She has unremarkable vital signs in the office today. What is your most likely diagnosis? So you see that they gave you a younger patient that has a history of an autoimmune condition in the hypothyroidism, and now is presenting with this biliary pathology. So in your mind, you should be thinking of what biliary pathology is kind of due to an autoimmune etiology, and you should be thinking here of biliary or primary biliary cholangitis. And the labs you'll see are, again, your cholestatic pattern, so elevated alk phos, a specific antibody that you should order in patients with PBC. What antibody is that? So that'll be your anti-mitochondrial antibody, and that's because primary biliary cholangitis is associated with a positive anti-mitochondrial antibody. Treatment for this condition typically involves ursodeoxycholic acid, which can help improve the itching. Now, a bit more about PBC. So the pathophys, as I mentioned, is due to autoimmune destruction of intrahepatic bile ducts. And this will be really important to differentiate PBC from an upcoming biliary pathology in PSC, or sclerosing cholangitis, in which case there's involvement of both extra and intrahepatic bile ducts. PBC, or primary biliary cholangitis, only affects the intrahepatic bile ducts on exams. The classic presentation is a female because on board exams, women are more prone to autoimmune conditions. They'll present with fatigue, itching, right upper quadrant pain, may have hepatomegaly, jaundice, or dark urine. And your ultrasound findings will generally be normal, actually, but you will be able to see findings on a ERCP. And biopsy may show that autoimmune destruction of the intrahepatic bile ducts. Today we have a 40-year-old gentleman presenting with right upper quadrant pain. His vitals are significant for a fever to 100.4 degrees Fahrenheit, and exam reveals scleral icterus. On kind of review of systems, you note that he has a history of hematochezia and some abdominal pain. What is your likely diagnosis in this patient? Two diagnoses often are confused with each other, so we just talked about PBC, and now we're going to talk about PSC, which is primary sclerosing cholangitis. So your next step in management for this patient, so what kind of lab or test in particular are you going to order for this patient? There's a specific test I'm thinking about, and it's something that's associated with PSC. So you should be obtaining a colonoscopy, and that's because ulcerative colitis is very, very strongly associated with primary sclerosing cholangitis, and you can start treatment with ursodiol and also ERCP with dilation of biliary strictures. There is one high-yield long-term complication of PSC that warrants monitoring in these patients, and that'll be an increased risk for gallbladder or cancer of the bile ducts, and there's a 10 to 15% risk of cholangiocarcinoma in patients with primary sclerosing cholangitis. So the significance of the bloody stools, as we discussed, that's significant for ulcerative colitis, which is very strongly associated. And there, again, there is an antibody very strongly associated with PSC. What antibody is that? So primary biliary cholangitis was associated with anti-mitochondrial antibody. So ulcerative or primary sclerosing cholangitis is associated with a P-ANCA, or perinuclear anti-neutrophil cytoplasmic antibody. On MRCP for PSC, you'll see beads on a string, and you'll see dilation or constriction, that beads on a string appearance of both intrahepatic and extrahepatic bile ducts. Whereas with primary biliary cholangitis, you would just see the intrahepatic bile ducts affected. On biopsy, you'll classically see onion skin fibrosis. Now, we're just going to quickly talk about choledochal cysts because they're sometimes tested, although fairly rarely, but you'll be a little bit more prepared now. So these will typically present with some obstructive symptoms and sometimes a palpable mass on exam. And you'll obtain imaging, either ultrasound or CT. And then the high yield thing to note is that if they give you a patient with these obstructive symptoms and they say, on imaging, you see that it's a choledochal cyst, you're not really concerned about malignancy, but the treatment will still be removal because there's a risk for malignant transformation to gallbladder cancer. And there's some of the things that increase risk for gallbladder cancer, which is most commonly an adenocarcinoma, but sometimes can be a squamous carcinoma about 10% of the time. But some risk factors you want to think of are chronic inflammation, a porcelain gallbladder, at least on examination purposes, chronic cholecystitis, and then your gallbladder polyps. And here are the different types of choledochal cysts. I really won't get into this too much. All right, our next case, let's say we have a 65-year-old woman. She's an immigrant from Southeast Asia and is now presenting with a several-month history of abdominal pain, weight loss, fatigue, and jaundice. She notes too that her stools have actually become lighter and are now clay-colored. You get some labs and you see an elevated CEA and CA19-9, and then an abdominal CT with IV contrast is shown on the right here. What is the most likely diagnosis? So anytime you see that abdominal pain with weight loss and fatigue, you'll want to be thinking of some kind of abdominal cancer, especially with the obstructive jaundice here. You want to be thinking about something involving the biliary tract. And then the findings of acolic stools or clay-colored stools also is concerning for biliary pathology. So elevated CEA and CA19-9 can be seen in colon cancer and in this cancer as well. And then your CT findings show, so this is the liver, obviously on the right side of the body, and you're seeing intrahepatic biliary duct dilation. So this is cholangiocarcinoma, and the CT findings kind of help you narrow that differential down. And this is typically an adenocarcinoma, but your differential diagnosis should include a pancreatic head mass, which can also present with very similar symptoms and an elevated CA19-9. So your next step in diagnosis will be an ERCP, and that's because you want to obtain some biopsies to confirm the diagnosis and get, usually they also will perform next-gen sequencing, although that's kind of beyond the scope of the shelf exam itself. And then some risk factors for cholangiocarcinoma. These are surprisingly high yield for the shelf exam. So you want to be thinking about PSC. So as we just discussed, PSC has a 10 to 15% risk for cholangiocarcinoma. And then also liver fluke infection, viral hepatitis, and liver cirrhosis. Our next case, let's say we have a 41-year-old woman presenting with severe epigastric pain with associated nausea and vomiting. She has had episodes of abdominal pain in the past associated with fatty meals, especially in the right upper quadrant. And today on her exam, she's tendered a palpation, most in the epigastrium. She's also in severe pain on exam. What is the likely diagnosis for this patient? You want to be thinking about acute gallstone pancreatitis. So you have the history of what sounds like biliary colic with the episodes of right upper quadrant pain associated with fatty meals. And today the pain is more epigastric and is severe and associated with nausea and vomiting. So that's all very classic for pancreatitis from gallstones. On CT, so you can get a CT to diagnose pancreatitis, although it's not necessary. you can see parenchymal edema, fat stranding, and peripancreatic free fluid. So treatment of pancreatitis typically involves supportive management, so IV fluids, because these patients can get a lot of third spacing of their intravascular fluid and lose it and third space it into extravascular spaces. Pain control, this is severe, very, very painful condition. And then managing any underlying pathology, which in this case would be the gallstones. And typically, for a specific acute gallstone pancreatitis, you want to perform a cholecystectomy prior to discharge of the patient, typically within 48 to 72 hours of admission. All right, moving on, let's talk about pancreatitis. So, the pathophys of pancreatitis, like we've alluded to in the past, is intrapancreatic activation of enzymes due to, in this case, obstruction due to a gallstone. But essentially, with any cause of pancreatitis, you get autodigestion of the pancreatic parenchyma due to pancreatic enzymes, the most common one being tryptase. And then you can also get direct pancreatic acinar cell injury, and that's most commonly due to alcohol that can cause pancreatitis as well. So I'm sure you've all by now heard the mnemonic for pancreatitis, but really the most common causes of acute pancreatitis are gallstones, are more common than alcohol. So gallstones cause acute pancreatitis about 40% of the time, alcohol about 30%, and then you have a smattering of other causes of acute pancreatitis, namely hypertriglyceridemia, drugs such as steroids like prednisone, diuretics. For some reason, thiazide diuretics are very, very high yield in causing pancreatitis, and then valproate, which is an anti-epileptic, and then direct trauma can also cause pancreatitis. It is high yield to know that in cases of hypertriglyceridemia induced pancreatitis, you can start an insulin drip, which will reduce triglyceride levels and can help improve pancreatitis. So there is mnemonic, I get smashed, but we kind of just went over the most common cause of acute pancreatitis. Classical clinical features of pancreatitis we talked about in the slide in the presentation of the patient. So you'll most commonly have epigastric pain that's severe that radiates to the back. And then this pain is worse after meals and often associated with nausea and vomiting. One other cause of acute pancreatitis I should mention is post-ERCP as well. So you'll see that more often clinically. It's not as tested as much on the board exams, although it is technically fair game. There are some board artifact exam features that we don't typically look for clinically, but can sometimes be tested. So that'll be Cullen's sign, which is periumbilical ecchymosis, and then Gray-Turner sign, which is flank ecchymosis or bruising, and then Fox sign, which is bruising over the inguinal ligament. Now, for diagnosis of acute pancreatitis, do we necessarily need imaging with a CT scan? You don't always need imaging for diagnosis. So you can make this diagnosis clinically, and that's if you have two of the following three diagnostic criteria for acute pancreatitis. So the first diagnostic criteria is classic abdominal pain. So that's your epigastric pain radiating to the back. Number two is your pancreatic enzymes being 3 times the normal limit. And that's typically lipase, although sometimes you may see amylase on question stems. Clinically, we just use lipase most of the time because amylase is less specific because amylase is in your saliva. And then if you don't have 1 and 2 fulfilled and you have a high suspicion, then you can obtain a CT scan. In clinical practice, a CT scan is more common because you want to assess if there's any necrosis or complications or anything like that for pancreatitis. And then one additional imaging tool that you can obtain is right upper quadrant ultrasound if you want to assess for gallstones, which again are the most common cause of acute pancreatitis. So more about the pancreas itself. So with pancreatitis, you can get some complications. So some local complications of pancreatitis include necrotizing pancreatitis and also formation of a pancreatic pseudocyst a couple weeks after an acute phase of pancreatitis. You can also see intra-abdominal compartment syndrome, and that's when there's intra-abdominal pressure that's greater than normal. I think the normal is about 5, and then if it's greater than I believe it's about 15 to 20, then you would have in abdominal compartment syndrome, and this will present with a tight, distended abdomen and nausea and vomiting. And you can also get end organ dysfunction in abdominal compartment syndrome. Some systemic effects of pancreatitis, as I'm sure you know, include ARDS, sepsis, and DIC, and it can also present with pleural effusions. And that's again due to the increased propensity for third spacing in pancreatitis and widespread inflammatory response, which can cause ARDS, sepsis, and DIC. Here is a cut from a CT scan, and this is with IV contrast, and you can see that within the abdomen, there is some ascites here, some free fluid in the abdomen, and then you can see that the pancreas is quite swollen, and then there is some edema in the peripancreatic fluid and the retroperitoneal fat. So this would be consistent with an acute pancreatitis. For our next case, let's say we have a 65-year-old gentleman presenting with a history of known significant alcohol use. Let's say he has 5 or 6 drinks of hard liquor a day. He's now presenting to your office with recurrent abdominal pain, diarrhea, and recent onset of night blindness. What is the most likely diagnosis for this patient? Thinking about chronic pancreatitis, especially given his history of significant alcohol use, an extended history of alcohol use. So treatment of chronic pancreatitis. So in pancreatitis, you kind of get loss of normal pancreatic function, both endocrine and exocrine pancreatic function. So treatment typically involves enzyme replacement, and chronic pancreatitis can also be quite painful, so also pain control. There is one intervention that can be done for pain control that's sometimes tested, and that's a celiac ganglion block. But this would be later in management for this condition if the pain is refractory to medications. And then you'll want to manage underlying conditions, which in chronic pancreatitis is typically alcohol cessation. So again, chronic pancreatitis is due to chronic inflammation and autodigestion, and eventually the pancreas will basically digest itself and it'll shrink and become very fibrotic. Some risk factors, most commonly alcohol use, but also tobacco and hypertriglyceridemia. And then there is one genetic risk factor, and that's cystic fibrosis. Like I mentioned, there is an exocrine enzyme deficiency in late chronic pancreatitis, which can cause GI symptoms and night blindness because you're essentially losing normal pancreatic function. So you'll lose a lot of your pancreatic enzymes, which will lead to steatorrhea, and then you'll get malabsorption of fat-soluble vitamins, which are D, A, K, and E, or DAKE, however you want to remember it. But vitamins D, A, K, and E will be malabsorbed in chronic pancreatitis, so you'll get presentations with deficiencies in each of these. So this patient in particular was presenting with a vitamin A deficiency, and that was the night blindness. So chronic pancreatitis diagnosed with CT scan and imaging finding. On imaging, you'll see some pancreatic ductal dilations and calcifications as well. There are some other pancreatic function tests that can be obtained in situations where you suspect chronic pancreatitis or you want to work up malabsorption, and that can include a fecal elastase, where a fecal elastase level greater than 200 signifies normal pancreatic exocrine function, because fecal elastase is an enzyme produced and secreted by the pancreas, and a level less than 100 indicates severe exocrine insufficiency. And a level between 100 and 200 is low but not severely decreased. You can also directly measure pancreatic function by administering CCK or cerulin, which is a CCK analog, and secretin, and then measuring the enzyme levels that the pancreas produces in response to those stimulatory enzymes. Some other complications of chronic pancreatitis include pseudocysts, diabetes, because remember your beta cells are located within the pancreas, malabsorption, ascites, and increased risk for pancreatic cancer. So here, you see some imaging. So on the left, On an abdominal x-ray, you can see that there are some chronic calcifications within the pancreas. And on the right, you can also see calcifications. Next case, let's say we have a 70-year-old woman presenting with a 50-pack year smoking history, and she's here in your clinic for a routine checkup. She does note to you that she's had a 25-pound weight loss over the last 6 months, and this has been unintentional weight loss. And on exam, you see jaundice and a non-tender right upper quadrant mass. What is the most likely diagnosis in this patient, and what would you do for your next step in workup? This should be concerning for a pancreatic adenocarcinoma, and treatment depends on the location of the pancreatic mass. So if the cancer is in the head of the pancreas, then you could consider for a surgical option a Whipple procedure along with adjuvant chemoradiation. And if it's in the tail of the pancreas, you could consider a resection of the body or tail with the splenectomy at the exact same time with adjuvant chemoradiation. And if it's unresectable, then biliary stent and chemotherapy to relieve symptoms. And this can be more of a palliative approach. So more about pancreatic cancer. So risk factors, the most common risk factor is smoking history, but also chronic pancreatitis, alcohol consumption, and higher age. The classic clinical features you'll see are the painless jaundice, epigastric pain, because that's where the pancreas is, and then systemic symptoms. So that'll include your red flag symptoms for cancer in general, like fatigue, weight loss, decreased appetite. On exam, there's a very high yield exam finding for examination purposes, and I'll let you try to think of it right now. I believe it's French. So it's Courvoisier's sign, which is when there's enlarged and non-tender gallbladder with painless jaundice. So this patient, you're able to palpate the gallbladder. It was non-tender but enlarged, and they also presented with jaundice. And that's a sign of more a pancreatic head mass, because that indicates that there's kind of biliary obstruction. Another sign that the examiners will sometimes give you in pancreatic cancer is Trousseau's sign of malignancy, and this is when there's a migratory thrombophlebitis, which is a kind of irritation of the superficial blood vessels that can be tender. When the blood vessels are tender to palpation, and it'll kind of migrate around the body, so it won't be in a single location. This is not to be confused with the Trousseau sign of hypocalcemia. And I believe that's kind of tetany with muscle spasm that can be seen with hypocalcemia. All right, so some labs that may be elevated are CA19-9 and CEA. And CA19-9 in particular can be a marker of pancreatic cancer progression. Imaging again is abdominal CT. Next, let's move on to discussing pathology involving the esophagus and upper GI tract. So let's say we have a 35-year-old gentleman with a past medical history significant for HIV. His last CD4 count was 49. He's now presenting to your clinic with adenophagia or pain with swallowing, and EGD shows linear ulcers. What is the diagnosis in this patient? So this is most consistent with CMV esophagitis, and treatment for CMV esophagitis is IV ganciclovir. And just remember that you use ganciclovir for CMV. So that's systemic CMV and also esophagitis. On biopsy, you may see what finding on histology. There's a certain buzzword that sometimes examiners will like to throw at you. So sometimes you may see atypical lymphocytes, specifically with intranuclear inclusion bodies, and those are the owl eye cells. And the way I always remember that treatment of CMV is with ganciclovir is one of my friends plays League, and he used this word ganking. So I always say you use IV ganciclovir to shut down the CMV virus. I don't know why that sticks. I don't even play League, fortunately, but for some reason that always stuck with me. All right, for our next patient, let's say we have a 35-year-old gentleman presenting with also the past medical history of HIV. CD4 count was 49. Also with the same history of adenophagia, but this time EGD shows well circumscribed, punched out ulcers. So what is the likely diagnosis for this patient? So here you should be thinking of HSV or herpetic esophagitis, especially with the punched out ulcers. And treatment for this will be IV acyclovir. And on biopsy, you'll see multinucleated giant cells. So this is what you'll typically see in the herpes family viruses, these multinucleated cells, and they may have eosinophilic inclusions. There's one also test that can be done for any herpes family virus, and it's a specific smear that I'm thinking of. And that would be the Zank smear, TZANK, Zank smear. And on that smear, you can see multinucleated giant cells as well. For our next patient, we have a 35-year-old gentleman again with a past medical history of HIV. Last CD4 count was 98. And this time, this patient is presenting with adenophagia, but EGD shows yellowish mucosal plaques. And let's say you can scrape them off easily. What is the likely diagnosis? So here you should be thinking of Candida esophagitis, and treatment will typically involve your azoles. So that can be fluconazole or voriconazole. We have a 65-year-old woman presenting with a recent diagnosis of osteoporosis that now has dysphagia and retrosternal pain. What is the likely diagnosis, and what are you going to ask her about or check the chart for in her history? So you should be thinking about pill esophagitis, and you're going to ask her in her history what new medications she started. And the specific pill in this instance is likely bisphosphonates. But some other pills that can cause pill esophagitis include NSAIDs, iron, and potassium, especially oral potassium chloride. So prevention of pill esophagitis, you essentially want to take pills with food and water, especially these high-risk pills, and be standing up or seated upright when taking these pills. For bisphosphonates in particular, we tell patients to remain upright for up to 90 minutes after taking bisphosphonates because of high risks of gastroesophageal reflux or GERD or heartburn, along with risk of pill esophagitis. Now let's say we have a pediatric patient, a 5-year-old, presenting with drooling and hematemesis after they are left unsupervised in the kitchen. And let's say when you see this patient, you see that there was a cabinet door open with the cleaning supplies. What's your likely diagnosis in this patient? You should be thinking of caustic ingestion, and the specific diagnosis being corrosive esophagitis. And for diagnosis, you want to be getting a endoscopy within 12 to 24 hours. Treatment for caustic ingestion is caustic ingestion is typically supportive, but you can use a NG or nasogastric tube if there are extensive circumferential burns. And importantly, on the test, the examiners are going to try to trick you, and they'll make one of the answer choices a neutralizing agent, but you do not want to use a neutralizing agent or activated charcoal. And what are complications of caustic injection or ingestion, rather? Some late complications involve things like strictures, but early complications can include esophageal perforation and respiratory compromise. Now let's say we have a 21-year-old college student who was out late last night for their birthday. And, it's a college student, so you can kind of guess what they are doing on their 21st birthday. Last night, so in clinic today, they say that last night they had multiple episodes of vomiting, but now they have severe retrosternal pain. On exam, you actually palpate some crepitus along the sternum. What is your likely diagnosis? What are you concerned about? So you should be concerned about esophageal perforation or Borhave syndrome. And another cause of this is also due to a recent upper endoscopy, but obviously not the case for this patient. In this patient, typically on exam purposes, it'll be due to retching or repeated vomiting. Treatment is typically conservative. So what that means is NPO, so you don't want them taking in anything or drinking or eating. And then acid suppression with a proton pump inhibitor and IV antibiotics as well. So some indications for surgery include hemodynamic instability and deterioration despite conservative management. There's some specific imaging findings you want to be thinking about. So on chest x-ray, what would you see? So you want to be thinking about a widened mediastinum. And then there's a gold standard test that's very often tested as the next best diagnostic test. So let's say they give you this clinical vignette, they give you the chest x-ray, and then they ask, what is the next step in imaging? You want to be thinking about a contrast esophography, which is a gold standard, and you want to be using gastrographin if you suspect a perforation, because if there's extravasation of the gastrographin, it will be less irritating to the chest structures. You can also obtain a chest CT. Next, let's say we have a similar presentation, another 21-year-old student after several episodes of vomiting last night, and they noticed some hematemesis with the last episode of vomiting and severe retrosternal pain, but you don't palpate any crepitus. What is the likely diagnosis in this patient? Thinking of a Mallory-Weiss tear, especially with that significant pain but lack of crepitus. Treatment of a Mallory-Weiss tear, again, is supportive. You want to give an antiemetic and a protein pump inhibitor. And then for tests, you can consider an EGD. Now let's say we have a 60-year-old gentleman presenting with halitosis, or essentially bad breath. And they give you the barium esophagram in the clinical vignette. And then they are asking you to identify the likely diagnosis. So here you can see there looks like a pouching of the esophagus. So what is a likely diagnosis for this patient? So you should be thinking of a Zenker diverticulum. Good. And is this a true or false diverticulum? And this is a false diverticulum because not all layers of the esophagus are involved in the diverticulum itself. Phys of Zenker diverticulum. This is a very high yield point because it'll also often be one of the answers. So a lot of times the examiners will give you clinical findings consistent with the Zenker diverticulum, but then in the answer choices, they'll ask which of the following is the pathophysiology of this. And the answer you're going to want to pick is that this is a weak point in the muscular wall of the esophagus between the thyropharyngeal and cricopharyngeal pharyngeal constrictors, which leads to that outpouching. Treatment. So this is a surgery itself, so you could consider surgery for symptomatic Zenker diverticulum, and that could be endoscopically or open. Next, let's say we have a 51-year-old gentleman presenting with chest pain, nighttime cough, hoarseness, and dental erosions. And these symptoms are worst with eating. What is your likely diagnosis? So you should be thinking of GERD, but another good thought would be atypical chest pain or atypical angina. But in this particular case, it's GERD, especially with the burning and hoarseness. So typical management of GERD, you start with lifestyle changes, eating less food, don't eat after 8 p.m., and then starting usually a trial of omeprazole or another protein pump inhibitor, and then you can wean down to famotidine as well. So typically you'll start with a trial of PPI. Your classic clinical presentation will be epigastric pain and burning. And there are some red flag symptoms that you want to be thinking about. So if you get any of these symptoms in the question stem, you want to be thinking about EGD or a upper scope because you want to do a more formal evaluation. So these would all be reasons to obtain an EGD if you want to obtain a biopsy for something like Barrett's esophagus or esophageal cancer. So let's say this patient didn't improve with a protein pump inhibitor and they say they've had symptoms for many years. what would your next step be? That's right. So we just talked about it. You'd get an EGD. And then if the biopsy showed metaplastic columnar epithelium with goblet cells, or they may also say intestinal metaplasia, what do you think about? So this would suggest Barrett's esophagus. Now let's say we have a patient with a history of GERD, now with dysphagia to solid foods. What does that make you think of? They will tolerate liquids. So it would make you think of an esophageal stricture. And treatment for this would involve EGD with dilation of the stricture. Now let's say we have a patient with GERD, again presenting with dysphagia, but also adenophagia, anemia, and weight loss. So what do you want to think about here? So this would be esophageal cancer. So that's what you would be concerned about, especially with the symptoms of anemia and weight loss. So you want to do EGD, barium swallow, CT for staging and looking for metastasis, and treatment will typically involve resection and chemoradiation. So risk factors for esophageal cancer are, as we already discussed, GERD, especially with Barrett's esophagus. I believe Barrett's esophagus has a 10% risk for transformation into cancer. And the important thing to know is that once a patient develops Barrett's esophagus, even if you improve the underlying GERD, the Barrett's esophagus doesn't always go away. The risk for cancer remains even after improving the GERD. And then smoking as well. Although smoking more increases the risk for squamous cell carcinoma of the esophagus and less so adenocarcinoma, at least for exam purposes. Okay, well, speaking of that, let's say we have a patient with a history of alcohol use disorder, now presenting with dysphagia, adenophagia, anemia, and weight loss. What's the most likely diagnosis? Let's say it's in the proximal 1/3 of the esophagus. This is more concerning for a squamous cell carcinoma of the esophagus. And common risk factors for this are alcohol, smoking, and HPV. And one way you can distinguish if this is an HPV-related cancer is the P16 genetic testing. So that if it's a P16 positive cancer, that means it's likely related to HPV. And these typically have better outcomes than non-HPV-related cancers. Now let's say we have another pediatric patient, a child presenting with stridor, wheezing, and dysphagia with solid foods. They show you the following chest x-ray. Ignore the caption. So this is a vascular ring. And for imaging, you can get a CT angio, which will show you the vessels constricting the trachea or esophagus. Right, now talking about the GEJ, gastroesophageal junction, let's say we have a 51-year-old gentleman presenting with a history of severe GERD that's recalcitrant to standard GERD therapies, and you see the following imaging. Let's see. I guess I didn't show the imaging. So this would concern you for a hiatal hernia, and the more severe variant of a hiatal hernia is a paraesophageal hernia. Surgical treatment, there typically involves fundoplication, and there are several different types of fundoplication depending on the amount of degrees. So I believe in Neeson's like 360 degrees around the esophagus when you wrap the stomach around the esophagus and connect it 360 degrees, the stomach with itself. And there's one that's like 270 degrees. And then you can get an associated ulcer called a Cameron ulcer. And here's what you'll see where you'll get herniation of the stomach into the esophagus, which leads to reflux. Now let's say we have a 51-year-old gentleman that is presenting with severe chest pain after eating. And this happens almost every single time he eats, but resolves after about 30 minutes. And then you obtain a barium swallow and you see this imaging on the x-ray. What is the likely diagnosis? So this should be more concerning for diffuse esophageal spasm, or DES. What is typical treatment of diffuse esophageal spasm typically look like? We should be thinking about some lifestyle modification, including eating smaller meals, and then also nitrates and especially calcium channel blockers. So the medication options, especially nitrates and calcium channel blockers, are very high yield for exam purposes. Clinically, also peppermint oil is an option that can be added for diffuse esophageal spasm, and then more aggressive interventions include Botox, dilation, and surgery. Now let's say we have a 51-year-old gentleman that has noted progressive dysphagia to both liquids and solids. So whenever you have dysphagia to both solids and liquids, you want to be thinking of a motility disorder. And then you see the following imaging. And you can kind of see, I have a picture on the right here of like a toucan or something like that with the bird's beak. And you can see that bird's beak sign on this barium swallow. So what's the likely diagnosis here? So this is achalasia, and treatment for achalasia is similar to that for esophageal spasm, where you can consider botulinum toxin injections, which relaxes the muscle, and also myotomy, which is a more aggressive approach. And that specific intervention is a Heller myotomy. And the pathophys of achalasia is atrophy of the inhibitory neurons of the esophagus, and the specific area of those neurons is in the Auerbach plexus. So you want to be able to differentiate achalasia, which presents with dysphagia due to increased muscle tone in the esophagus, and you want to be able to differentiate that with scleroderma. So scleroderma, the most common organ that it affects or area of the body is actually the esophagus. And it'll present with very similar symptoms of motility disorder, causing progressive dysphagia to solids and liquids. But on manometry, you'll see reduced tone in scleroderma. So reduced tone, scleroderma. And then in achalasia, you'll see increased tone on esophageal manometry, which just measures the pressure. All right, next we'll talk about stomach pathology. So let's say we have a 51-year-old woman with a history of significant alcohol use and severe knee arthritis. They're now presenting with epigastric pain and dyspepsia. What is the likely diagnosis, or what are you concerned about in this patient? So you should be concerned about acute gastritis, especially with a history of alcohol use and at the same time knee arthritis, which can be treated with NSAIDs. So NSAIDs plus alcohol, not good for the stomach lining. So some tests or treatments you can try are trial of protein pump inhibitor to reduce acid. So acid suppression therapy, acid suppression. And stop these, right? Bad, not good. And if there's no further improvement, then you want to consider further workup. Now let's say we have a 51-year-old woman that immigrated from Mexico 6 years ago, and they're presenting with epigastric pain. A trial of a protein pump inhibitor is providing limited benefit. What is the likely diagnosis for this patient? So 51-year-old woman again that is an immigrant from Mexico, and they also have epigastric pain. So here you want to be thinking of H. pylori gastritis, and classically H. pylori gastritis affects what anatomical region? That's the stomach antrum. So some specific tests you can obtain for H. pylori gastritis include a urea breath test, but you can also do an EGD with a scope. Biopsy rather. So you'll do an EGD and then obtain a biopsy and culture that for H. pylori. Treatment of H. pylori is triple therapy or quadruple therapy if patients are allergic to amoxicillin. But triple therapy involves a acid suppression medication, so protein pump inhibitor, amoxicillin, and a macrolide, typically clarithromycin. So in monitoring for treatment of H. pylori, you want to first do this EGD with biopsy. And then after your treatment, which I believe is several weeks, I think around 4 weeks or so, you want to assess to see if that treatment was successful with a repeat. So you'll get H. pylori stool testing, and it should be negative after triple therapy. All right, next, let's say we have a 51-year-old woman presenting again with epigastric pain. Exam demonstrates peripheral neuropathy. And you obtain some labs that show an anemia, hemoglobin of 10.1, and it's a macrocytic anemia with MCV of 110. What's the likely diagnosis in this patient? So here you want to be thinking about atrophic gastritis or autoimmune gastritis. And the pathophys of atrophic gastritis or autoimmune gastritis is that there's destruction of parietal cells, which commonly affects the fundus of the stomach. And you may see that sometimes the examiners will say, you know this patient has atrophic gastritis. What specific antibody may be found? And it'll be antibodies against intrinsic factors. So IF or intrinsic factor antibodies. And of course, parietal cells are required for absorption of B12. So this patient is presenting with a vitamin B12 deficiency, causing a macrocytic anemia. Now let's say we have a 39-year-old gentleman presenting with gnawing epigastric pain, and he states that the pain is worse after meals. What diagnosis? So this one's kind of a read my mind question, but this is a peptic ulcer, and specifically it's a gastric ulcer. And the way you can differentiate a gastric ulcer with a duodenal ulcer is that a gastric ulcer will have worse pain after meals because you'll be producing acid. So some risks of peptic ulcer are, of course, H. pylori and then also NSAID use. Again, NSAID equals not good for the stomach lining. And a test you can obtain is EGD, and you want to get a biopsy in any case of a gastric ulcer because there's a risk of associated malignancy. So very high yield to know if you see a peptic ulcer on an exam and they ask you the next best step, you want to get an EGD with biopsy due to risk of malignancy. Next, let's say we have a 39-year-old gentleman presenting with gnawing epigastric pain. So the same kind of clinical vignette, but this time he says the pain improves after meals. So what's the diagnosis this time? So here you want to be thinking of a duodenal ulcer, again, because the pain improves after meals. And that's because the duodenum produces bicarb due to secretin release. It's mediated by secretin. So your duodenum will have more bicarb, which will relieve symptoms when you eat. So risk of duodenal ulcer, this is actually more commonly associated with H. pylori because it's a little more distal, so you need more acid production. And there's a lower risk of associated malignancy with duodenal ulcer when compared with a gastric ulcer. Another high yield fact to know is that H. pylori, does H. pylori invade into the stomach itself? Or does it kind of chill outside? So does it invade in? Or does it hang outside of the gastric lining? Yeah, so it's important to know that the H. pylori hangs out outside the gastric lining. So it's a superficial infection, which just stimulates increased acid production within the stomach. So it doesn't actually invade into the stomach. All right, now let's say we have a 39-year-old gentleman presenting with gnawing epigastric pain again. And then you see that this patient has multiple jejunal ulcers. So you may say that's kind of weird. That's pretty distal. What is the likely diagnosis in this patient? So here you want to be thinking about Zollinger-Ellison syndrome or a gastrinoma, which essentially causes hypergastrinemia because this is a gastrin-producing tumor. And you get increased stimulation of parietal cells and therefore increased production of acid. You get either like recalcitrant ulcers or really distal ulcers, such as at the jejunum. So confirmatory tests. So some labs you can get in ZES or Zollinger-Ellison syndrome are serum gastrin greater than 1,000 and a secretin stimulation test. So normally secretin should inhibit gastrin secretion, but if gastrin remains very, very elevated, even after administering secretin, then that's a confirmatory test for Zollinger-Ellison syndrome. And what syndrome is ZES associated with? That's right. So you should be thinking of MEN1 syndrome. So this is a curling ulcer, and you can remember that because a curling iron is hot and they can cause burns. And this is due to decreased plasma volume and also a component of hypoxic tissue injury. And for prophylaxis, you just want to make sure these patients have a PPI. I think most patients in the ICU should have a PPI. And then what's the ulcer called if a patient has severe head injury now with hematemesis? So that's a Cushing ulcer. And the pathophys of a Cushing ulcer is due to increased vagal stimulation, which is parasympathetic, and lead to increased production of stomach acid via acetylcholine, which activates parietal cells. So here's this picture. I don't know if it's supposed to show up first, but look how intense he's looking at you. He's watching you. I guess if you know his name, you'll get this question right. But what's an anatomic name or anatomic cause of hematemesis due to a aberrant artery? So it's a Dieulafoy lesion. So this guy's name, old Draco Malfoy. And that's how I've been remembering the Dieulafoy. Because Dieulafoy lesions can be life-threatening in hemorrhage. So I remember that's life-threatening hemorrhage is bad. And Malfoy was our bad guy. He's a bad guy in the first books of the Harry Potter series. All right, now this one I just kind of gave to you, but let's say if there's a patient with cirrhosis and bleeding from the stomach,
severe burns,
and you note
greater than 20% total body surface area that's admitted to
in
the
stomach
SICU or the surgical ICU.
but they're
let's say the intern was
you don't
on
have a name
and
for
they
it,
forgot to order a specific
so you
indicated
can get
prophylactic
esophageal
medication.
varices.
Now this patient is
Cirrhosis
presenting
due to
with
increased
hematemesis.
portal hypertension.
What is the likely diagnosis?
But these
And
are
it's a
called
specific
GAVE, or
name for a
gastric
type of ulcer
antral
this
vascular
patient has.
ataxia, which are essentially esophageal varices that affect the stomach, and most common in portal hypertension. Next, let's say we have a 70-year-old gentleman presenting with epigastric pain, weight loss, and early satiety. And on exam, you palpate supraclavicular lymphadenopathy, and his hemoglobin is 10.5. So what are you thinking of here? And really, the early satiety is a warning sign that you want to be thinking about, and the weight loss as well. So here you want to be thinking of a gastric adenocarcinoma. And for the next step, you want to obtain EGD with biopsy for confirmation. Treatment typically involves surgical resection or palliative care. So some risks of gastric adenocarcinoma. So a lot of these are diet related. So high salt diet, hot and nitroso containing compounds. So like processed meat, tobacco, some pickling agents as well. Pickling. Chronic H. pylori and chronic autoimmune gastritis. And some specific tests that you want to obtain are an EGD with biopsy, of course. So a high yield association is that a Kruckenberg tumor, which are bilateral ovarian tumors or ovarian masses, indicate metastatic disease from adenocarcinoma. And again, these are kind of more exam associations, but I've seen these
before on some exams, so I just threw them in there to be complete. And then there is a lesser trait loss sign, which is the sudden appearance of many seborrheic keratoses for exam purposes. And then you can also see perineoplastic acanthosis nigricans. So these are most common in perineoplastic findings for gastric or other GI tumors. Now let's talk about some colon pathologies. So, brief overview of cause of colonic dilation. So, first we want to think about colonic dilation in terms of mechanical obstruction versus non-mechanical obstruction, or megacolon. And specifically, the definition of megacolon is when you have colonic dilation without evidence of obstruction. So, there are a few causes, so three main causes of megacolon that are commonly tested. The first one is acute megacolon, where you have colonic dilation due to something like electrolyte imbalance, such as an Ogilvy's, that will cause Ogilvy's that happens over a short period of time, or megacolon that happens a short. Ogilvy's is acute megacolon that happens over a short period of time. Chronic megacolon is often neuropathic in origin, such as with Chagas disease, which again is caused by T. cruzi, which is a parasite, and that can also cause dilated cardiomyopathy. And Hirschsprung disease as well can cause a chronic megacolon. Toxic megacolon can often be distinguished down to a infectious, such as C. diff, or inflammatory colitis, such as ulcerative colitis. And treatment for toxic megacolon often involves bowel rest, IV antibiotics, and surgery if there's no improvement after 48 to 72 hours. So here we see AUB of the large intestine, and you see that there is likely large bowel obstruction, especially with this very dilated colon, and you may be able to see a distal large bowel obstruction. So another imaging study or imaging modality you could consider for this patient would be a CT scan. And there is a specific part of the small bowel that we measure, and that is the colon that we measure in cases of large bowel obstruction. That is the cecum, because that is the weakest part of the colon. All right, so moving on the right hand side, we have an image, and these are those UWorld questions that take you that lower your average time, because these questions take you like 3 seconds. So you see a coffee bean colon on the right hand side here. What is the likely diagnosis? So this is a sigmoid volvulus, and again, you want to recognize that coffee bean shape, because a coffee bean kind of looks like that. I don't know. I got all my coffee ground, so I don't really see the bean. So if a patient is stable and there's no evidence of perforation, how do we treat a sigmoid volvulus? So typically we'll treat with a flexible sigmoidoscopy, or flex-sig, versus a colonoscopy. And what we'll do during that flex-sig, and you might see on question stem, is detorsion, which is basically currently the colon is wrapped around itself, and we just want to make sure it's runs like it's supposed to. So that is called detorsion, when we basically straighten the colon back out. If the patient is unstable, there's evidence of perforation, then they'll need to have a surgical procedure for likely colectomy or resection of part of the colon. Like they might take this out or something. Right, this is a long case. Let's say we have a 45-year-old gentleman presenting to clinic with a 1-week history of abdominal pain. So let's read the last question and see what they would like. So they'd like the likely diagnosis. All right, going back, let's say they describe left lower quadrant tenderness that has been increasing over the last couple of weeks. They note changes in stool habits recently, and they have a long-standing history of constipation. They do have a history of a lap appy. On exam, you see moderate abdominal distension, and their diffusely tentative palpation worse at the left lower quadrant. You get some labs in clinic, and you see that they have a leukocytosis to 17,000. What is the likely diagnosis in this patient? So overall clinical picture, we have a 45-year-old gentleman presenting with abdominal pain worse at the left lower quadrant over the last couple of weeks, and a leukocytosis. and they have a long-standing history of constipation. So what is the likely diagnosis in that clinical vignette? And the next step in treatment or the next step in diagnosis of diverticulitis will involve a CT scan with both PO and IV contrast. And then you want to be looking for paracolic fat stranding with diverticulitis, which is diagnostic. So management of uncomplicated diverticulitis typically involves antibiotics, and you can even manage with PO antibiotics or oral antibiotics. And typically, a course of Cipro or Augmentin can be appropriate for management. If the diverticulitis is complicated or they have significant symptoms, like they meet Sir's criteria and are septic, or they appear to be sick, then you want to initiate IV antibiotics, typically something like with anaerobe coverage like piptazo or piperacillin. And you can also consider drainage of the abscess versus surgery. So some complications of diverticulitis. So there are three main ones, and that is an abscess formation. Because, right, so you have your colon. Again, I'm not an artist. And you have these outpouchings, and those are the diverticuli. And they become inflamed. So when they become inflamed, they can fill and be kind of filled with bacteria and pus, which can form an abscess. You can also get inflammation that leads to an obstruction. You also get perforation, where the diverticulitis will perforate into the abdomen. And then you can also get fistulas. So you can get things like a colovesicular fistula, where let's say you have your bladder here, and you can get a fistula from a diverticula into the bladder if there's inflammation and they're bordering each other. Okay. So moving on to other general surgery topics. So let's say we are starting with our fistula friends. So the friends mnemonic for formation of fistula. So we just talked about one example of a fistula in diverticulitis. So I don't know if anyone knows this song from SpongeBob. So the F is for friends who do stuff together. But in this case, who needs enemies when you have friends like these? So starting with F. So F stands for what? So F stands for foreign body, and R stands for radiation. For some reason, I have radiation first, but F stands for foreign body, R stands for radiation, I stands for inflammation or infection, E stands for epithelialization, N stands for neoplasm, D stands for distal obstruction, and S stands for steroids or short track. So these are all predisposing factors for fistula formation. All right, now let's talk about ostomies quickly. So there are a lot of different types of ostomies. So you can have a colostomy, you can have an ileostomy, and you can have within that different types as well. So you can have a endostomy. So an endostomy is when you take the bowel. Let's say you have a colostomy, and you take the bowel, and here's the end, and you bring that up to the skin. Whereas a diverting loop ileostomy is when you have an anastomosis you want to protect, and you can bring up a different area to the skin and let the stool pass through this area and protect your distal anastomosis. So if you want to learn more about ostomies, but I have found a diagram of different types of ostomies here. So here you have an example of a loop ostomy, where you bring part of the entire loop out to the skin and have the ostomy there. Here's an endostomy. So this is basically ostomy that, let's see if I can change my color here. So this is an endostomy where you take, this is a part of the colon or the ileum, and you bring out the entire lumen out to the skin. So this is basically a permanent ostomy. Or well, you can reconnect it, but it's more difficult with the endostomy. Here is a type of a pouch. All right. Here are some more types of ostomies. All right, now let's say we have a 62-year-old presenting with fatigue. He is not followed regularly with a doctor in the last several years, so he does not doctor. And he has a history of a sleeve gastrectomy 5 years prior for morbid obesity, and he has since lost over 200 pounds since his surgery. So he's been very pleased with his outcome, but now he notices fatigue that's happened over the last few weeks or months. You get some labs, and you note a hemoglobin of 8.1. Cells and platelets are within normal limits, but MCV is 112. So what is your next step in diagnosis, and what kind of questions will you be asking him? So you want to ask what vitamins he's been taking, because he has a macrocytic anemia in the setting of a gastric bypass. So bariatric patients should be, taking a bariatric multivitamin, which includes B12, calcium, vitamin D, iron, and vitamin C, because bariatric patients can develop because you're taking out part of the stomach. Here's a good video that I'll link in the description. So with the sleeve, you can take out, part of the stomach here. You have decreased absorption of. So thus you have to supplement these, or you'll be deficient. So this patient in particular likely has a vitamin B12 deficiency, which you can confirm with a vitamin B12 level and methylmalonic acid. So let's say we have a 65-year-old gentleman with a 35 pack year smoking history that's presenting with a blood pressure of 80/50 and severe abdominal pain that radiates to the back. What's the likely diagnosis? Let's say you're working in the emergency department. This is a AAA rupture. So one high yield question they may ask is, what is the screening age for a AAA? And that is age 65. Some other high yield tips about AAA. So if the AAA is greater than 5.5 centimeters or rapidly expanding, so if it increases, I believe this should be 1 centimeter in 12 months, then that's an indication for AAA repair. Please correct me if I'm incorrect, but I believe it's 1 centimeter. And you can also get neural complications with a AAA rupture. And that's because you have your aorta, right? And you have your renal arteries, you have your femoral arteries, you have your iliacs. So what is a high yield complication of AAA rupture? So you should be thinking of anterior cord syndrome, because the blood supply to the anterior cord, there's only one blood supply to the anterior cord. So you can have anterior cord syndrome due to ischemia in a AAA rupture. And you can also get an ischemic bowel. But you can also get renal ischemia as well, because you have your renal arteries right there. All right. And then I found this ad. Well, unfortunately, I drew over it, but more doctors smoke Camels than any other cigarette. I've never seen that fact tested, but it's an ad, so it must be true. So if you see a question about what cigarette type doctors smoke, the answer is probably going to be Camels, because it says so in this ad. Please don't take that seriously. Okay. Next, we have a 65-year-old gentleman with a 35-year pack year history presenting to your clinic with bilateral foot pain. So he notes that his lower legs and feet hurt every single time he walks to the end of his driveway. He has a history of tobacco use and hyperlipidemia. What's the best next step in diagnosis? So you should be thinking of ABIs, or an ankle brachial index, because you're concerned about what disease. So you should be thinking about peripheral artery disease. And the typical clinical history you'll get with PAD, or peripheral artery disease, is that patients will be able to walk a set distance, and every time they walk to the end of their driveway, they will experience that pain. Distinguish between neurogenic claudication, because oftentimes in neurogenic claudication, patients will have that shopping cart sign. Let's see if I can draw a shopping cart. Patients will be more relieved with their spinal stenosis when they lean over like that. Whereas with peripheral artery disease, these patients will experience leg pain every time they walk to the end of the driveway or a certain distance. Okay, so classic symptoms: limb pain after walking a specific distance. And treatment for PAD involves graded exercise, which is the primary treatment. but that is mostly for symptom management. So note that if graded exercise, if a question stem asks, let's say this patient has PAD, and then they ask which of these therapies would improve expected mortality, the answer will always be smoking cessation. Honestly, on any shelf exam, if you see smoking cessation, you better have a good reason not to put it. But then you also usually want to start dual antiplatelet because it's a coronary artery disease equivalent, and you can also consider psilocybin as a pharmaceutical option for symptom management. Typically, ulcers in peripheral artery disease are located at the distal toes because this is where blood flow is the most tenuous. So you may see like a distal ulcer here. And if it's a chronic non-healing ulcer, they can develop osteo, which can warrant amputation. So this would be a transmetatarsal amputation, but can progress to tibial or even BKA, below the knee amputation. So there's a risk for gangrene with these ulcers, these arterial ulcers. All right, so this is a kind of a pimp question, but I've seen it tested a few times. Let's say you get asked, what is the aortoiliac triad? And I can give you the symptom constellation. So let's say they have hip, thigh, and buttock claudication, impotence, and also diminished femoral pulses. So this is Lariche syndrome, and so sometimes they may give you in the question stem that they have these symptoms of hip, thigh, and buttock claudication, impotence, and diminished femoral pulses, and they want you to say that the cause of the obstruction is in the aortoiliac triad, and there's probably some atherosclerosis there. All right, next, let's say we have a 60-year-old woman presenting with pitting edema of the bilateral lower extremities with erythema, pruritus, and purpura with brown hemosiderin deposits and scaling. I don't know if a dermatologist wrote this or something because it's awfully specific, but I guess venous insufficiency, specifically venous stasis dermatitis. And over time, this can develop lipodermatosclerosis, which is a more irreversible form of the skin findings seen in stasis derm. All right, so in stasis derm, where is the ulceration typically observed? So remember in PAD, the ulcers were kind of usually the distal toes. So for venous ulcers, typically it involves the medial malleolus. All right, and treatment for venous stasis. So yep, that'll be your compression stockings and keeping the feet elevated above the head of the bed when possible. So, sometimes patients will sleep on a pillow like that because then blood flow will be flowing downwards. So you'll want to keep the affected area above the level of the heart. The heart is here somewhere. All right, so some conformational imaging that you can obtain is an ultrasound, and there you can see that there's reflux or just stasis of the venous flow. Now let's talk about how the endocrine system is tested on the surgery shelf. So let's say we have a 60-year-old patient that's 6 hours post-op. So they just got out of the PACU after a thyroidectomy and now is developing difficulty breathing, and exam shows a palpable neck mass. So this would be concerning for a neck hematoma. And what is this due to? What was not done properly intraoperatively? This is typically due to insufficient hemostasis. So your next step will be re-exploration of the wound, and you want to make sure you secure the airway, which may sometimes require intubation. What are some other complications of thyroid surgery? So let's say a patient is hoarse. What would that indicate? So that could indicate superior laryngeal nerve injury, or you can also have injury to the parathyroids. So here's your thyroid gland. So you can get a hematoma that bruise and causes some airway compromise. So you want to go in, make an incision, and then probably drain out that wound and make sure there's adequate hemostasis. Okay. Now let's say we have a 50-year-old with a thyroid nodule that's asymptomatic. What's the best next step? In terms of lab testing, you'll want to get a TSH, and then this will be followed by an ultrasound. If there are any suspicious features, so if the lesion is oval, there's an irregular border, or calcification is greater than 1 centimeter. What's the next step? Then you want to obtain a fine needle aspiration, or FNA. And what is the most common thyroid cancer? So that would be a papillary thyroid cancer. But what's a more common hereditary cause of thyroid cancer? The medullary thyroid cancer. And treatment for thyroid cancer typically involves surgical resection. All right, very good. And there's a post-op medication we give post-parathyroidectomy for cancer, and that's T4. And you also want to monitor calcitonin in medullary cancer. So you would give T4 to suppress TSH and suppress growth and decrease growth of thyroid tissue, which reduces risk of recurrence. All right, let's say we have a 55-year-old with a thyroid nodule. She has a past medical history of a prolactinoma that was resected. Fine needle aspiration shows a medullary thyroid cancer. She also has a family history of a mother and an uncle on the maternal side with medullary thyroid cancer as well. Her labs were consistent with a medullary thyroid cancer with elevated calcitonin and hypocalcemia. What's the best next step in workup? And I've gotten burned on this question a few times. So the next step will be 24-hour urine metanephrines, because you want to rule out pheochromocytoma. And you also want to obtain genetic testing, likely because of suspected MEN2 syndrome. So if this patient does have a pheochromocytoma, what pre-op medications do you want to give this patient? You want to have it symptomatic blockade, right? Because pheochromocytoma, especially with the stress of surgery, can cause like uncontrolled hypertension intra-op. But you don't want to administer beta blockers directly, because this will cause unopposed alpha action. So what you do first is you give an alpha-1 blocker, specifically phenoxybenzamine, which is a more long-acting alpha-1 blocker, and then afterwards you will administer a beta blocker. So that way you'll have both alpha and beta action. Good. So these are from the movie Airplane. So this is MEN2 syndrome. So just briefly talking about MEN2 syndrome is that you'll have an increased risk of medullary thyroid cancer and pheochromocytoma. So whenever you see these two together, you want to be thinking about MEN2, or multiple endocrine neoplasia type 2. So this is due to a RET gene mutation and is autosomal dominant. And then MEN2A in particular is associated with medullary thyroid cancer, pheochromocytoma, and parathyroid hyperplasia, whereas MEN2B is associated with medullary thyroid cancer, pheochromocytoma, mucosal neuromas, and marfanoid habitus. But these are both under the MEN2 category. And here on the left, you can see diaphoresis. This is the pilot from the movie Airplane, starring star actor Kareem Abdul-Jabbar. But this I kind of always think of this scene when I think of pheochromocytoma, just with the sympathetic activation. All right, now briefly talk about MEN1, because it's very easily to get MEN1 and 2 confused. So MEN1 is the 3 Ps. So that's your parathyroid, your pituitary, and your pancreatic lesions. So with your parathyroid lesions, you can get adenomas like a prolactinoma, but also hyperplasia. Or rather, sorry, with the parathyroid, you just get adenoma or hyperplasia. And then with your pituitary involvement, you can get prolactinoma or symptoms of pituitary mass, such as bitemporal hemianopsia. And with the pancreatic mass, you can get tumors like a gastrinoma, like with Zollinger-Ellison syndrome, or a VIPoma, which is WDHA syndrome, which is watery diarrhea, I believe hypochloremia, and I think acidosis. And then MEN1, again, is the MEN1 gene and is autosomal dominant. And here's a picture of MEN1. So it affects P number 1, pituitary, P number 2, parathyroids, P number 3, pancreas. Next, let's talk about how dermatology is tested on the surgery shelf. So let's say they give you a patient and they give you these following lesions. So I would call those spots on the face and scalp, but it looks like whoever described these, which I think was me, said it's a 75-year-old gentleman, presenting with rough, gritty, scaly plaques with hyperkeratosis over the face and scalp, and he recently retired from a long career of farming. What's the likely diagnosis? So this, even I can figure this one out. So these are those gritty spots. That's actinic keratosis, and this is a precursor to squamous cell carcinoma. I believe there's like a 1% risk annually, so about a 10% risk over 10 years of malignant transformation to squamous cell carcinoma. So I actually did a derm rotation before, and in derm clinic, typically these are treated with cryotherapy, but on the boards they want you to do something else. So specifically on boards, actinic keratosis should be biopsied because there is a risk of squamous cell carcinoma. And then treatment still involves cryotherapy, or if it's extensive, like in this patient, you could consider 5-fluorouracil, which is Fudex, for field treatment, or imiquimod. All right, this is a classic. This is another one of the UWorld questions you see, and you just go in and you click the right answer. So let's say it's a 60-year-old gentleman presenting with a cup-shaped tumor filled with keratin debris, and it's grown rapidly over the last several weeks. So what is the diagnosis? It's a keratoacanthoma, or a KA, and this is a form of a squamous cell carcinoma, or a well-differentiated squame. And treatment, so on board exams, they can regress on their own, but in clinic, we typically just want to treat these with excision. So on board exams, you still want to cut it out because it's a skin cancer. Cut it out! Exclamation point. Okay. Next, we have a ulcerative red lesion with scaling. So what type of skin cancer is this? It's scaly. Look at the scaling. All right, looks like a squamous cell cancer. That would be correct. And S for second most common skin cancer. And on biopsy, you'll see mostly look for the keratin pearls, but also you'll see cellular pleomorphism where they don't all look the same, and you'll see hyperchromatism. And there are certain patient demographics that have an increased risk of squamous cell carcinoma, and that's immunosuppressed patients, such as transplant patients, and then patients with a chronic scar or wound, and that's specifically called a marginal ulcer. So for excision, you want to have 4 to 6 millimeter margins. Technically, I think 6 is required for a squamous cell cancer, but it depends where it is. And then for squames in situ, you can do excision, but you can also do like electrocurettage or cryotherapy and curettage, where you will freeze the area and numb it up, and then you'll scrape it off, and you'll freeze it again, scrape it off, freeze it again, scrape it off for a total of 3 times. You can also do some topical therapies like Fudex or imiquimod again. So this is just a quick question. What is it called when there's a squamous cell carcinoma in situ? So it doesn't extend past the dermis, or the epidermis rather. So this would be Bowen's disease. All right. Now the other common type of skin cancer. Let's say we have a patient presenting with a waxy pink pearl-like papule with rolled borders and central ulceration with telangiectasia. What is this most consistent with? Basal cell carcinoma, which is the most common type of skin cancer. And biopsy will reveal your basophilic staining, and you'll have the peripheral palisading. Peripheral palisading, PP. Treatment typically involves surgical excision again with a 4 millimeter margin, and Mohs can be done in high-risk areas such as the face. Actually, interestingly, Frederick Mohs was a med student when he came up with Mohs surgery. He was actually in the department of surgery, so maybe that's why they put it on the surgery shelf, or maybe it's because of the fact they call it Mohs surgery. And this, it's important to know basal cell carcinomas rarely metastasize. And this is a pathoma artifact I left on my slides, but if they ever ask you about if skin cancer is on the upper lip, then it's more likely a basal cell. And if it's on the lower lip, it's more likely a squamous cell. And his little mnemonic is BS. This is BS that we have to know it, which it kind of is because you'll usually just biopsy it, or you can tell by looking at it. But here's an example of what a basal cell looks like. You can see those rolled borders. Even I can see those. And the telangiectasias, which are those blood vessels at the surface of the skin. All right, here's some more examples of basal cells. This is a superficial basal cell, and this is a scar-like basal cell. All right, so let's say we have a 65-year-old presenting with a spot on her back that she noticed while showering. Let's say she looked in the mirror and noticed it. She doesn't know if it's grown or not. What's the best next step? So here you want to get an excisional biopsy. Maybe you'll cut like an oval like that and then stitch it up, because this would be concerning for a melanoma. And the most important prognostic factor for melanoma is what? So you should be saying the breast lobe thickness or the depth of invasion. So the deeper the invasion of the melanoma, let's say here's our skin here, here's the dermis. So the deeper a melanoma is, especially if it's greater than 1 centimeter or 1 millimeter rather, then you want to be more concerned with how advanced the melanoma is. So there are a couple different types here of melanoma: your acral lentiginous type, your nodular, superficial spreading, and lentigo maligna. Superficial spreading being the most common. And treatment typically involves a wide local excision, plus or minus a sentinel lymph node biopsy, depending on the Breslow depth. And you want to take at least 0.5 centimeter margins, even for a superficial melanoma or a melanoma in situ, and then up to 1 centimeter margins, depending on the Breslow depth. Here's an example of an acral lentiginous melanoma. Burn. So let's say we have a 35-year-old gentleman presenting after being rescued from a house fire, and he's unresponsive at this time. On exam, you see extensive burns involving his entire back, chest, and front of his right leg, and you also note singed hairs on his face. What's the best next step? So just like an acute trauma situation, you want to first manage the ABCs. So here you have a patient that's unresponsive. So already, you can do his GCS score, but because he's unresponsive and you notice singed hair on his face, that's an immediate indication for intubation for airway protection. And now I'm going to ask, how much fluid resuscitation should you administer according to the Parkland formula? Let me erase this stuff for you, and you can reread the question. So I'll give you the affected body parts. So the affected body parts again are the entire back, chest, and the front of the right leg. What is the percent TBSA involved? So first we can calculate the total body surface area. So we have the back, which is 18%, plus the chest, which is 18%, plus the front of the right leg, which is 9%. So that's 45. Okay, great. So we have 45% total body surface area. And the Parkland formula states that you want to take the percentage. So the percentage of TBSA mils times 100. And that'll give you how many milliliters you want to administer over the next 24 hours. So according to the Parkland formula, then we would have 45 times 4 times 100, and that's 18,000 milliliters within the next 24 hours. So how much of this 18,000 milliliters should the patient receive within the first 8 hours? So they should receive half. So that's 9,000 milliliters within the first 8 hours. And then what is another indication for intubation in burn patients other than a low GCS score or not being responsive? For intubation is evidence of upper airway involvement, so that could be blisters or edema on a bedside laryngoscopy. And here's your rule of 9. So the front and back of the head and neck combined is 9%. Each of the front of the chest and the back are each 9%. So the front of the chest and abdomen would be 18%, and the back is 18%. And the front leg is 9%, and the back leg is 9% as well. All right, so moving on. So the Parkland formula again, 4 mils times the total body surface area times, and the affected surface area can only be 2nd and 3rd degree burns times the weight. So this is like your deep burns, because they don't really use the classification of 2nd and 3rd anymore. And then you want to administer half in the first 8 hours and the rest of the next 16 hours. And we prefer using lactated ringers. And that's because you want to prevent acidosis due to the chloride present in LR. And then what guides resuscitation after initial management? So the initial 24 hours, you use the Parkland formula to guide resuscitation. But after that, you want to be using urine output, and you want to titrate to 0.5 ml per kg per hour of urine output. But make sure these patients have a Foley catheter in early so you can measure the urine output. So there are a few other adjuvant therapies we give severe burn patients. So typically for severe burn, we say that if a patient has greater than 20% burn, if they're between ages 10 and 50, or less than 10 or greater than 10% burn if they're less than 10 years old or greater than 50 years old. So you want to also give testosterone and a PPI. And the PPI is for acid suppression to reduce the risk of ulcers, like we talked about in the beginning of this talk. All right. Now, what kind of surgery is performed if a patient has a circumferential burn, and why? So let's say they have a burn on their arm and arm like that. What kind of surgery do you want to do? So here you'll do an escharotomy. So that is, you want to prevent compartment syndrome. And then there is a surgical option for burn patients, and that's skin grafting, where you can place skin from other parts of the body like the thigh and take a graft of skin and then place it over a burn site. So there's some burn classifications. So there's a superficial burn that affects only the epidermis. So this could be seen after a patient gets a burn after putting their hand on the stove briefly, and on exam you see erythema, and the burn site is painful and blanches. So that'd be a superficial burn that affects only the epidermis. Next, let's say we have a patient that has a burn after spilling hot water. On an exam, they have blistering, painful, and blanchable burn. And really note the blistering component. So this would be a superficial partial thickness burn, which involves the epidermis and subdermis. So this would formally be a second degree burn. And let's say another patient comes with a burn, and on exam they have a non-blanchable, painless burn, but pressure sensation is preserved. So this would be a deep partial thickness burn, which I believe would still, in the old classification, have been a second degree burn. And this involves the epidermis and some of the dermis, and you have disrupted blood flow, which is why this burn's non-blanchable, and nerve damage as well. Although it does involve the complete dermis, so you still have intact pressure sensation. Lastly, let's say we have a patient with a burn after fire, and on exam, the burn site is non-blanchable, non-painful, and has a waxy or leathery appearance, and deep pressure is preserved, but that's the only thing that's intact. So this would be a full thickness burn, and this involves the epidermis and the full dermis. So that's all we've got. Thank you all for watching, and thanks to Quinn and Jackson for helping me make these slides last year. And if you have any questions or suggestions or comments, be sure to leave a comment on this video, but you can also email strudelreview@gmail.com. All right. Have a good one, everyone. Peace.